Good morning. And so this is non-invasive biomarkers in kidney transplant, and taking you away from a lot of other medical aspects to the lab. The point is that why is there now a focus on molecular predictive biomarkers? And the reason for this is there is an unmet need. There is a need to improve the variation in histological biopsies. I'm not saying that pathologists are not doing a good job, but there is a lot of variation internationally where we need to improve and standardize. So there's a need for precision, accuracy, standardization, and personalization. Diagnostics is changing, and we know that, and we are going through that era right now. We are becoming more precise in our measurement, and we are moving away from pattern recognition, which is precisely what a lot of path diagnosis is based on. And the biomarkers are needed for post-transplant surveillance because there are long-term outcomes for transplant that are not improved much over the past decades. The immune suppression ridge out there is narrow, too little, too much, and that can cause a problem. Also, what we're doing right now is a one-size-fits-all, and is that actually fair to the patient? So the immune responses that we look at in transplantation as of today are driven by alloreactive T and B lymphocytes. Now, detection of alloreactive T cells, the tests which are available for this lack sensitized methods, lack validated methods. So our current immune risk stratification is absolutely almost entirely directed at humoral effector pathways. So we're only talking about antibodies. So the current approach is assessment of DSA, antibodies again, and this is what we really need to change when we bring in the T alloreactive methods to help us in our diagnosis. Also, in the post-transplant period, we are looking at non-invasive tools for clinical decision-making, basis which can become the basis for targeted pathogenesis-driven therapies. The current surveillance methods have limitations. We have the serum creatinine, great, very reliable, used over the years. The nephrologists absolutely love it, but it's not specific, it's not sensitive, and may increase only after considerable damage has occurred to the kidney. The DSA has a poor positive predictive value. Surveillance biopsies are out. There are issues with biopsies, complications, and issues with inadequate biopsies. We also have the immune suppressive drug monitoring as a surrogate for rejection. So the essential features for minimally invasive biomarker in transplant is it should be able to detect early and exclude acute or chronic rejection. Asymptomatic graft injury and subclinical rejection should be picked up, and assessment of minimum immune suppressive drug dosage it should be able to support. So looking at the molecular window using technology, we have the molecular presentation, which is the first presentation that comes. We don't see it. And here is the cell-free DNA, which is intertwined with gene expression. The second is the subclinical, which is intermediate. That's where the DSA, the biopsies, the infections, the CMVs, etc. come in. And finally, what lags far behind is the clinical presentation. And we're trying to get to the molecular presentation. So you're looking at the molecular markers. Now, if you ask me what is the golden molecule, there is none as of today. So what we actually have to work towards is a multi-parametric molecular approach and do a little mix of tests to get where we want to get. The omics of molecular biomarkers in transplant. So we have the genomics, the transcriptomics, the proteomics, and the metabolomics. So omics in the pre-transplant picks up the anticipating organ performance, whereas in the post-transplant it is directed at monitoring. So the transcriptomics looks at the measurement of damaged gene expressions, and there is this gene expression profiling, which is on the NGS. There are a host of other tests, not many of them have really worked so far. And there is the tissue injury related test where the cell-free DNA donor-derived stands. So the rationale of using donor-derived cell-free DNA as a biomarker is that organ transplants are in effect genome transplants. And that's what the principle to make use of over here. And why is cell-free a biomarker of choice? A whole lot of reasons. It's present in plasma, saliva, urine. It's also individual specific, but what's really important is it gives you a real-time picture of what is happening. So it has a very short half-life. So it's what's happening right now. Now, if we look at the dynamics of the post-transplant cell-free DNA kinetics, and this is from a study which was done earlier, right in the beginning when they looked at cell-free DNA, the values go up definitely immediate after transplant, but over a period of time they decline and stabilize. And that's what's important. When we look at a monitoring test, you need to have baseline values, which is also the reason why you cannot start doing this test right up when you do the transplant. And we recommend 14 days wait period, but actually the values come down to normal before that, but the recommendation is 14 days. So there was the DART study which looked at serum creatinine performance and cell-free DNA. It also looked at the ability of cell-free to discriminate active rejection from no rejection and ABMR from non-ABMR. And that's the result of one of the older studies. The test was great at differentiating no active rejection from active rejection when 1% was the cutoff value. Whereas when you looked at the same cohort in the creatinine, there was no difference in the no rejection versus the rejection. So that's the huge comparison with creatinine, a test we all love. But cell-free DNA is also highly sensitive as a test in distinguishing ABMR from non-ABMR. If you look at the graph there, ABMR, the values are high, real high. But if you look at the DSA positive with no ABMR, so DSA is positive, but we can't depend, that's why, entirely on the DSA. But cell-free DNA is negative, that means there's no rejection happening there. And of course, the DSA negative also had a cell-free as negative there. So the authors here, Jordan et al., recommended a combined use of donor-derived and DSA, which can improve the non-invasive diagnosis of ABMR. If you look at the other tests which came up, another study with the same objective came up later in 2020, and they also looked at the ABMR, the DSA negative, ABMR no, and also DSA negative stable and DSA positive stable. So this category does exist where you can have DSA without actually having an ABMR. Also, the test has a great negative predictive value, and at 1% cutoff. So that's a case study of a DSA positive repeatedly biopsy, did not repeatedly no ABMR, and the cell-free continues to be less than 1%, means there was no rejection in this case. And that's another case where there was a significant rise in cell-free DNA associated with ABMR. So there was cell-free was at about 3.7%, which is real high. Allograft biopsy, day 30-60, all was negative, but then there was a sudden rise indicating that there was an injury which did happen and caused rejection. The test is also great at monitoring rejection treatment, and so it need not biopsy to monitor response to therapy, or just look at creatinine. So you have active rejection therapy. Within 1 month, the values are known to come back if there is good response. And definitely by 2 to 3 months, all the values are back to below the cutoff. So that's a longitudinal monitoring. We had this case, C4D focal positive. There was creatinine, which was at 2.2, and significant rise in cell-free DNA, rose sharp from 0.8 to 3.3% in a span of about a month, which quite clearly shows that there was rejection there. And this is another longitudinal monitoring graph we have, and just goes to show that how the values gradually go up, which is the whole point I want to make about a monitoring test. You need to look at the trend. A single point will never give you an answer, at least not enough for you to take action. So values steadily 0.4, 0.7, 1.5, and so on. And that's another longitudinal, just a graph to show how chaotic sometimes the graphs can look and how scary they can probably be for the clinician as well, up and down and back to normal and high again. But it does give a very clear-cut idea of how the individual is responding to therapy. So looked at the impact on outcomes and de novo DSA. Now, cell-free DNA, they looked at it. DS negative cell-free DNA was at a 0.2%, 0.20%. Preformed DSA, the values were at about 0.30%. But patients with de novo DSA had higher values of cell-free DNA at about 0.75%. That's not me. And so we had higher cell-free DNA levels are associated with de novo DSA formation. So it is now developing as a test which is giving a good indication of the development of de novo DSA if 0.5% is taken as the cutoff there. So as a test, it can be used for high risk, for continuous monitoring, as a surveillance for the others, but yes, the highly sensitized need to be more stringently monitored as compared to those who are quite not so sensitized. And that's a case study where we had a biopsy. The first cell-free was at 0.59%. They did a biopsy, but that was negative. It was negative because it only showed muscle tissue. And we repeated a cell-free a month later, 3 months later, and we got a value of 0.71%. But the biopsy at that point was there too with acute on chronic ABMR. So you got an indication that you need to look at him again and closely to be able to pick up the injury that is happening to the kidney. And also helps with titrating at what time points to go out and do a biopsy. So have a high cell-free, do a biopsy. So it helps you decide when you actually will go out and do a biopsy if you're monitoring with the test persistently. Clinical settings beyond rejection, and that's a small point I want to make with the BK virus. So it is a donor-derived cell-free DNA and the prediction of BK virus-associated nephropathy, and this came out in Transplantation Direct 2020, when they said when it's BK viremia itself, the values are normal, but when the viremia converts to nephropathy, there is a rise in cell-free DNA, and there are now centers which are using cell-free to even monitor the BK viremia versus the BK virus there. So a little bit about the gene expression profiling in kidney, because it's non-invasive. And so there's another test which looks at the immune classifiers. So there are tests which are available which look at 11 immune classifiers, but 5 gene immune classifiers mentioned here, the ones which are really effective in transplantation. And if you look at a combination of cell-free DNA, which is a marker for tissue injury, gene expression profiling of the immune markers, together the two tests make a fantastic non-invasive tool for transplant surveillance. And that's where we stand as of now. So I conclude with precise, accurate risk stratification of allograft injury and failure is important. Next generation biomarkers, not just cell-free DNA, but gene expression. Gene expression tests are now available even on the tissue. So one can look at, if you look at the BHOT panel, it can go up to 758 gene expression markers. Of course, how one really gets to the analysis and the outcome, one doesn't know. But yes, if we look at smaller gene expression markers on the tissue or in the peripheral blood would have to be immune markers because those are the best which go up. Then in kidney transplant, it can improve the prognosis of long-term renal graft, allograft outcome through early detection and taking appropriate correction or preventive measures. Also, the aim is here to improve clinical transplant outcomes, tailor therapeutic strategies, because the world is moving towards tailored, targeted therapy. We're not looking at whole protocols for everybody across the board, and then also incorporate risks for adverse outcomes to minimize benefits and maximize harms. So the challenges and what really lies ahead for us is to optimize the clinical utility of cell-free DNA in India. It's easy to extrapolate a protocol used in the West and say, okay, we're going to do the same, but I think we should and we will get to a point where we know how we want to do it for our country and what suits us best given our vast experience from the clinical side. We need to have accurate prognostications and trends, appropriate timing and frequency of donor-derived testing and surveillance needs to be determined, planned, donor-derived testing at various predefined intervals. And of course, there's a therapeutic angle. I've only given the viremia angle to BK viremia and cell-free DNA, but measurement of cell-free DNA and assessing treatment response in the realm of kidney transplantation, comparison of immune suppressive drugs, and longitudinal changes in cell-free. And if I look at some of the recent literature I've seen, there's a lot of correlation of the TTV, which monitors the drug levels, immune suppression levels with cell-free DNA. So those are the latest updates on what's happening in transplant from the lab diagnostic side. And thank you. Happy to take questions.